Hi all, and welcome back to Professor Truelove's Concepts for Nurses series. And in this episode, we will be discussing increased intracranial pressure, how it manifests itself, how dangerous it is, and any interventions that can be used to help preserve the patient's life. Sources for this episode include Igi's Medical Surgical Nursing, 9th edition, and Soule et al., Introduction to Critical Care Nursing, 7th edition. Increased intracranial pressure is associated with many neurological problems and is at the root of many neurological syndromes as either a primary injury or a secondary injury. As such, any patient who has sustained an injury to the central nervous system is at risk for increased intracranial pressure, or IICP. Normal cerebral compliance occurs when an increase in one of the three components of ICP, that is, brain tissue, blood, or cerebrospinal fluid, increases and then one or both of the other components decrease. Increased intracranial pressure results when there is an increase of one of the three components comprising ICP, again, brain volume, blood, or CSF fluid. Cranial contents are encased within the relatively rigid skull, and within this space there is little room for any of the components to expand or increase in volume. Therefore, the pressure exerted by the combined volumes of any of these three components is, by definition, intracranial pressure. If the volume of any one of these three components increases, the volume of one or both of the other components must decrease proportionally, or an increase in ICP occurs. This is Monroe-Kelly. This is compensation is termed compliance. You should know that increased ICP is the leading cause of death from head trauma in patients who reach the hospital alive. Increased ICP may be caused by trauma, hemorrhage, growths or tumors, hydrocephalus, edema, or inflammation. Further, increased ICP can impede circulation to the brain, can impede the absorption of CSF, can affect the functioning of nerve cells, and lead to brainstem compression and death. A quick review of the mechanisms of increased intracranial pressure starts with the increase of intracranial volume from either brain, blood, or CSF, or a combination of those, a decreased or absent compliance, resulting in increasing intracranial pressure and decreasing cerebral perfusion pressure, resulting in a decreased cerebral blood flow, which decreases PaO2, increases PaCO2, and decreases pH. These three lead to vasodilation, which causes increased intracranial volume, repeating the cycle over and over. In order to understand the ramifications of abnormal ICP, it's important to understand how normal ICP is regulated. Normal ICP usually runs from 0 to 15 millimeters of mercury and responds to things such as blood pressure, the respiratory cycle, isometric contractions, coughing, and things like Valsalva maneuver. Through a process of accommodation and compliance, ICP is maintained at its normal level of 0 to 15 millimeters of mercury, despite periodic increases in pressure that occur with straining during defecation, coughing, or sneezing. Any increase in volume in one component must be compensated for by a decrease in the volume of one of the other components. An increase in intracranial volume is compensated by displacement of CSF into the spinal subarachnoid space or displacement of blood into the venous sinuses. As long as the brain can compensate for an increase in volume and remain compliant, increases in ICP are minimal. However, as ICP increases, cerebral perfusion decreases, leading to tissue hypoxia, a decrease in serum pH level, and an increase in the level of carbon dioxide. This process causes cerebral vasodilation, edema, and a further increase in ICP. If the condition remains untreated, the brain may herniate downward toward the brainstem, causing irreversible brain damage and possibly death. This graph demonstrates how ICP can remain normal despite increases in volume, and it's demonstrated by the flat part of the curve. However, when compensatory mechanisms are exhausted, small increases in volume can lead to a large increase in intracranial pressure, and that's demonstrated by the steep part of the curve. In the healthy patient, this is accomplished through autoregulation, where there is an automatic alteration in the size of the cerebral arteries. It is temporary in nature and is sensitive to changes in blood pressure, changes in PaCO2, that is, in higher levels, there is a tendency to vasodilate, and PaO2 in lower levels cause those same vessels to also vasodilate. The most common cause of increased intracranial pressure is cerebral edema. There are two main types of cerebral edema: cytotoxic and vasogenic. Cytotoxic includes intracellular swelling of neurons and is caused by hypoxia or hypoosmolarity. Vasogenic, there is increased capillary permeability and is generally caused by tumors and meningitis. This increase in cerebral blood volume can be caused by several mechanisms: the loss of autoregulation, which provides a constant blood volume and cerebral perfusion pressure over a wide range of mean arterial pressures, can occur with head injury. The loss of autoregulation leads to decreased oxygenation, hypercapnia, increased metabolic demands, and obstruction of venous outflow. The other remaining mechanisms have implications for nursing interventions commonly implemented for patients at risk for increased intracranial pressure. These include, but are not limited to, things like seizures, hyperthermia, shivering, hyperactivity, and pain. The final component contributing to intracranial pressure is cerebral spinal fluid. Manipulation of CSF fluid volumes by draining off excess CSF is often used in the critically ill, where a reduction of blood volume or brain tissue is not effective. Increased cerebral spinal fluid causes hydrocephalus, that is, from a blockage of normal flow or an obstruction of normal reabsorption or the excess production of CSF fluid. As ICP increases, cerebral perfusion decreases, leading to tissue hypoxia, a decrease in serum pH level, and an increase in the level of carbon dioxide. This process causes cerebral vasodilation, edema, and a further increase in intracranial pressure. If this condition remains untreated, the brain may herniate downward toward the brainstem, causing irreversible brain damage and possibly death. These type of patients, therefore, need to be monitored for a proper perfusion to the brain tissue, also known as cerebral perfusion pressure, or CPP. In order to calculate that number, you should take the mean arterial pressure, subtract the intracranial pressure to equal the cerebral perfusion pressure, or MAP minus ICP equals CPP. Your average should be between around 85 millimeters of mercury, that is between 70 and 100 millimeters of mercury. It must be more than 65 millimeters of mercury to prevent cerebral anoxia. You should be able to calculate it whenever measuring intracranial pressures. Infants can also suffer from IICP, and those symptoms include a bulging fontanelle or soft spot, cranial suture separation, an increased head circumference, lethargy, and vomiting. For older children and adults, the symptoms of IICP include a change in LOC. As a matter of fact, a change in LOC is the most sensitive and earliest indication of increasing ICP. Later on, the patient may complain of headaches, there may be pupillary changes, abnormal respirations, elevated temperature, and nausea and vomiting. Other symptoms of IICP in older children and adults include blurred vision, changes in behavior. Late signs include the rise in blood pressure with widening pulse pressure and a slowing of pulse. Changes in motor function from weakness to hemiplegia, a positive Babinski reflex, decorticate or decerebrate posturing, and seizures also indicate increasing intracranial pressures. Based on the fact that intracranial pressures are influenced by things such as blood pH, oxygen levels, carbon dioxide levels, and electrolyte levels, it's important that the nurse obtain arterial blood gases, CBC, coagulation profiles, electrolytes, serum osmolarity, and urinalysis and osmolarity. Remember, serum osmolarity and urinalysis and urine osmolarity indicate how much oncotic pressure those two substances have, and that will have a direct effect on the edema in the brain. For radiographic or other types of diagnostics, they include CT of the head, MRI, cerebral blood flow with transcranial Doppler, evoked potentials, EEG, and even angiography. Nursing management for IICP include frequent and constant assessments, neurological examinations, and examination of the vital signs looking for signs of Cushing's triad. Positioning should be maintained with the head of the bed elevated at 30 degrees unless there are signs of a lack of cerebral perfusion. The head should be in a neutral position, and the patient should be turned from side to side for pulmonary and integumentary reasons. However, when the patient's turned from side to side, that will affect their ICP, so watch the patient for a return to baseline CPP. The patient should be suctioned only when necessary. They should be pre-oxygenated, and the suctioning should be limited to 10 seconds or less. And so a medical goal of IICP is to provide for adequate oxygenation with the goal of maintaining a PaO2 of greater than 80 millimeters of mercury. This requires airway vigilance and even mechanical ventilation using such modalities as positive end expiratory pressure, which should be used with caution, that will affect CPP, and to maintain adequate hematocrit. The priority management of a patient with increased ICP is focused on ensuring a patent airway. In addition to ensuring a patent airway, oxygenation must be supported, and this is because both CO2 and O2 levels have an effect on ICP. There used to be the practice of hyperventilating to decrease carbon dioxide levels, which would reduce the vasodilatory effect on cerebral blood vessels, and this has been abandoned because there is a potential for ischemia with that procedure. Nonetheless, there is a place for carbon dioxide management. The carbon dioxide level of your patient should be maintained between 35 and 45 millimeters of mercury. You should be able to avoid hyperventilating your patient with maintaining an ICP goal of less than 20 millimeters of mercury. Besides manipulating the size of the blood vessels, another way to manage intracranial pressure is to change the amount of water volume, and that can be accomplished through diuretics, including osmotic diuretics, to reduce brain tissue volume. This can be accomplished through mannitol or hypertonic saline. In fact, loop diuretics can be used to reduce brain tissue volume and decrease CSF formation. So osmotic and loop diuretics act to reduce brain tissue volume. Osmotic diuretics draw water from the extracellular space to decrease ICP. This effect occurs within minutes of administration. Loop diuretics remove sodium and water from injured brain cells. To maintain adequate cerebral perfusion pressure, fluid administration guided by hemodynamic monitoring must be optimized with the adequate fluids. Now, these osmotic diuretics work so well in withdrawing fluid from normal brain tissue that rebound cerebral edema may actually occur. This means that the healthcare team needs to monitor very carefully specific gravities and osmolarity of blood and urine. Management of vasospasms associated with subarachnoid hemorrhage, those patients often need higher fluid rates to prevent vasospasms. So as far as fluid administration goes, you should have optimized fluid administration with isotonic solutions, strict intake and output with a goal of maintaining serum osmolarity of less than 320. Colloids or blood products should be used to restore blood volume. Patients with increased ICP will have problems maintaining blood pressure, so the team needs to maintain a goal of having an MAP between 70 and 90 millimeters of mercury. This should maintain the CPP of at least 70 millimeters. So avoid hypertension because this increases cerebral blood volume, and this can be accomplished by using medications such as nicardipine. You should avoid hypotension because this causes ischemia, and this can be accomplished by the use of various vasopressors. Medications relevant to these kind of treatments can be found in SOUL, page 370 to 372, table 13-9. Monitoring and managing metabolic demands is yet another goal of the team, and this means temperature control. This may include induced hypothermia, with that goal be to maintaining the patient's temperature between 34 and 35 degrees centigrade as a way to reduce the metabolism of the brain. It may also be accomplished by the use of sedation, using such agents as benzodiazepines, propofol, analgesic agents, maintaining seizure prophylaxis, and even paralyzing the patient using a neuromuscular blockade. It may be, however, despite the team's best efforts, that surgical management of ICP will be indicated. This means the patient may need anything from a burr hole, the introduction to a monitor and draining device, or even craniotomy as necessary and as dictated. That does conclude this episode of the Neurological series, where we've been covering increased intracranial pressure. There is one more in this series, and in that case, we'll be talking about brain tumors and a small segment about brain death. Unpleasant business, but we have to cover it. So we'll see you then.